Right, shall we get going? Right, good afternoon, everyone, and welcome to this meeting of the Integrated Care Partnership. To begin with, first establish if we have apologies. I have apologies listed from John Goulston, Claire Bell, Richard Smith, Kate Langford, and Neil Dixon. Does anyone else have any other apologies? Nope. Okay. Certainly I'm advised that based on the responses to the invite, we can confirm the meeting is due to be quorate, and looking around, it looks pretty quorate to me. So welcome to all those who are joining us. There are no virtual participants, so this will actually be quite an old-fashioned meeting in one sense. And now, clearly, at last meeting, we had a number of issues in relation to AV. So I think just to emphasise, I'm sure actually I'm doing this myself properly, that you should stay relatively close to the microphone. So hopefully I was still audible at that point. It is asked that people introduce themselves in the meeting. I would suggest that we've all got nameplates here. What I would suggest is when you speak for the first time, you might wish to say who you are, but otherwise I don't think it is necessary beyond that. And clearly, if need be, if there's anything that is unclear, then for the purposes of those listening into the meeting, I will ask someone to clarify or to repeat if necessary. And finally, I'm told to mention that the venue will require all attendees to vacate, but at 5:30. So hopefully we should all be very well done by then. But please do be aware that should there be any reason for staying on here, 5:30 is absolute sort of kicking out time. So that is quorum we've addressed. Declarations of interest. Are there any interests to declare? I think we have all in Shane.
Thanks very much, Chair. Just to say, I submitted my form some considerable number of weeks ago, but it doesn't look like they've been recorded here on the form. So just for the minutes, for some reason...
Actually, sorry, Shane, I didn't quite catch all that. Can you just repeat? Yeah. Sorry.
I'll go and hug it. There we go. That's a bit better. Just to say, for some reason, the interest form that I submitted some considerable weeks ago doesn't appear to have been registered here on the form. So just almost for the notes that I have submitted it in time for the last meeting, and yet it doesn't appear to be here. So whereas others have been recorded. So just wanted that noted, that if that's okay, Chair.
Okay, thank you. We'll make sure we look into that and make sure that that all round it's updated. I don't know if anyone else has a similar experience, but otherwise there are no further interests to declare, anything else above and beyond what's already recorded in the declarations, assuming that they are up to date. Right, minutes of the previous meeting. This is our meeting of 27th of July. I think this is at this stage simply a question whether anyone has any queries on this as to whether they are anything other than a fair record, any amendments, challenges. I do know of one thing, which is John Goulston is referred to at one point as chief executive, when I think the term should be chairman or chair, and he did ask that to be recorded. Does anyone else have any other amendments to the minutes? If not, we'll take those as a fair record of the meeting. Then, in terms of the action log, I think it mentions here there are 2 actions, both recommended to close based on respective updates on the log. You can see you have that before you. Are you content that those are closed? Okay. Fine. Then we can move on, I think. Just making sure I've not missed anything else. No, if we're then, I believe we can move on a little bit ahead of time, which is good, in terms of our first substantive item. and this relates to the Kent and Medway economic strategy and its linkage, the links between economic opportunity and health outcomes. Delighted to welcome two colleagues from Kent County Council, Stephanie Holt-Castle and David Smith. Clearly you have the papers as well before you, but Stephanie or David, I don't know if there are some points you wanted to raise before we consider what is in the paper and the annex.
Thank you very much. So I'm Stephanie Holt-Castle. I'm the Director for Growth and Communities at Kent County Council, and I'll hand over to David in just a moment, who is the lead for the economic strategy. David is much more eagle-eyed than I am, so he spotted in the minutes that you'd actually already started this discussion at your previous meeting. So I'm going to skip the bit about why and how skills, employment, security of income, housing all contribute to people's people's health outcomes, and just probably move to the economic strategy is very much born out of a key piece of work that started during COVID about how do we support Kent and Medway's economy, and then it's very much how do we now build on that as we come out of the COVID crisis, but very much building on the fact that was a health emergency that had major economic and continues to have major economic impacts. How do we start to further bring together Kent's economy and Kent's health ambitions? From the KCC perspective, the economic team is now part of Growth and Communities. So again, this was a really good opportunity to look at how we do bring those agendas together. And you may have spotted in the background paperwork that as part of Priority 4, we've been quite explicit that we do intend the Kent and Medway economic strategy to really contribute towards tackling the health outcomes of Kent and Medway. I think the final thing I'll say just before I hand over to David is in terms of the emerging KCC public health strategy, there's again a real focus on what's the economic opportunity. So we're taking forward that work with the KCC public health team. But the economic strategy in front of you this afternoon is very much for Kent and Medway. So we're delighted to have a discussion with you about how you think we can best come together to make sure that we're maximising those outcomes. So on that point, I'll just hand over to David, who, as I say, is the lead for the economic strategy at the County Council and on behalf of Kent and Medway.
Good afternoon. I'm David Smith, the Programme Director for Business and Enterprise at the Council, Kent County Council. And I think has been said, we led the work that was the basis of this strategy during the COVID crisis. And it taught us very clearly one thing. If we work extremely closely and collaboratively with our partners in Medway Council, with the districts, with the health authorities, business, universities and industry, we were going to have an impact which we couldn't do if we simply ran it out of a room in our Invicta House in Maidstone. So this successor document, this successor strategy, takes us beyond COVID. It, with the work we did, has involved quite a lot of consultation with our partners over the past year, and we have taken it through a committee called Kent and Medway Economic Partnership, which has endorsed this. So it has got the endorsement just before the summer of the group that brings together the 14 local authorities in Kent and Medway, plus business, plus the universities and a number of others. And I'll describe some of the detail of it and how we believe, as I think was said at the first meeting of this partnership group here, that combining the work on the economy with the work on social care and health, we will be able to tackle some of those causes of health inequalities and problems in the community. And so we've deliberately built into this economic strategy these other outcomes, and we've deliberately built into it that partnership working in order to deliver those outcomes. Again, at your first meeting, there was a very extensive analysis of the relationship between economic and social deprivation and poor health outcomes. And that's true not just in Kent and Medway, that's true across the country. So part of the work of our economic strategy has been to look at what's happened elsewhere in the country and steal good ideas from them, share them, make sure they work, we think they would work for Kent and Medway. And I know that some of the ideas have been pioneered already in some of the districts. So Swale worked with the Breaking Barriers team very effectively, and that was looking at social inequalities and health and looking very specifically at actions that borough could take. And that's an example of the kind of integrated thinking that went into the papers that you've seen in advance of this meeting. Just to tick a couple of boxes, you have in your priorities list 7 priorities, and we think that what we can do is to work alongside you on your priority 6 and priority 7, which is setting our integrated care system strategy and ICB joint forward plan, including our shared ambition and deliverables. And your priority 7, which we think, again, we can work on an integrated manner, is leading the development of our ICS, developing our places, provider collaboratives, and how all our partners work together to be a high-performing ICS. So this I would hope, and this is for you to discuss and consider, we have 2 complementary strategies. We have your healthcare strategy, social care strategy, and we have our economic strategy. Our economic strategy, we were ambitious. We set a timetable of 2022 this year to 2030 because we thought in economic terms some of the things will take time to deliver. But on the other hand, we're impatient, and the current economic crisis has made things more difficult. So we're focusing now, in the remaining part of this year, on how we deliver aspects of that strategy immediately and with high impact on those things which we can make a difference quickly. But in terms of health and social care, I'm guessing that improving the economic outcomes, which will be much harder as a result of what's happened in the world markets and the war in Ukraine, we can still make a very big difference. And so we've got a program described in the strategy, and it is a strategy, it's not an action plan. We're working now, and we will be working with our colleagues in the other councils and Medway, and I hope Mr. Jarrett will endorse this. We've been all over each other, really, over the past 18 months in making sure that we've pinched ideas from Medway, and I hope you learn something from what we do. And an example of that is our people element of the economic strategy, which is employment. Hitherto, it was called skills, and a lot of people had worked diligently on improving quite a low skills base across Kent. We changed the name, and Mr. Goff now chairs an employment task force, which brings together, we hope, all those involved in making our youngsters, as well as the people in mid-career and those who've retired and might want to come back to work, get better prospects for employment, because having employment and having better pay is one of those key determinants of better health outcomes. And that's very clear. It is a cause and effect. It's not just 2 things happening together by accident. It is shown that if we, and other people have done it in Manchester, for example, have focused on some economic outcomes, and it's been associated over a number of years with improvement in health outcomes. So we're shameless in saying that it's not just making people wealthy. The reason for an economic strategy is to improve the health and well-being of individuals, the families, the people who want to come and work here. But it also does that by working with business so that there are better prospects of employment, and working with our education establishments, the colleges, the universities, plus the private sector providers and the schools, to ensure that those people who are looking for work have that opportunity by having better skills and better opportunities. So there are a number of strands, and one of the parallel pieces of work I think I would suggest we do together, taking it forward, is to agree some key outcomes, joint outcomes, and we work back from those outcomes to see what best we should do to deliver those. And that work from your first meeting, having key measures of performance, and I know the observatory is going to work on that and improve that, and we will use some of those to determine and guide the work we're going to do in turning our strategy into outcomes. I don't think we should go, I should take you through the papers which you've seen, but we have some key themes which I invite you to tell us whether we got them right from your point of view, which is that the strategy should focus on our economy being more productive, being sustainable, and inclusive. Those are the three watchwords we've tried to test everything in our strategy. And we've got 5 ambitions, and that gets into the specific guiding actions, which is enabling innovative, productive, and creative businesses. And I know quite a lot of your work involves contracting to partners in business, so it is going to help them, but also the work of your teams can benefit from business-like procedures and some of the things that have already been started, which is to help those people who are retiring from health employment to set up their own operations, suiting themselves as they've left with experience and skills, set up their own businesses in social care. And that's a kind of thing that we do business support with small businesses to help them think about what makes them sustainable. What we would do is include those fledgling businesses in the care industry, care sector, to learn the best business practices, how to look at cash flow, how to think about regulation. So the second is to widen opportunities and unlock talent. The third is secure resilient infrastructure for planned and sustainable growth. So a piece of work that we're doing across Kent Medway is a design guide for new development and to build into new buildings, new developments, a healthy environment, rather like historically. We've tried to build in a secure and crime-free environment, is to enable the developers to get their planning approvals to ensure that the new developments of the future in Kent Medway match our ambition for healthy communities. The fourth is putting economic opportunity at the centre of community renewal and prosperity. And the final is create diverse, distinctive and vibrant places. And I've noticed again that place is quite an important part, a determinant of health outcomes. There are places which are basically unhealthy and aren't conducive to good health. So that's part of our, I hope, shared outcomes. I won't go into more detail, Chairman, but I think we leave time for you to tell us what you think.
Thank you, David, and Stephanie, thank you as well. Now, this is quite a knotty subject, as these things often are, because it is, I think we all recognise, and as the paper sets out, the linkages running both ways between, if you like, economic well-being and health and care outcomes. But it does work both ways, because clearly a healthier and active population will be more economically productive, but equally you will find that the activities in this space themselves can have a significant economic effect. And one of the key points which guidance around integrated care strategies and the rest emphasises is the role of many of the organisations represented here as anchor institutions, the part that they play in relation to workforce, estates, etc., etc., etc. So the question of how I think we can all recognise that we need to ensure that there's a sort of common thread here. It's exactly how best we get that delivered and organised. And I would just, before throwing it open, and I have got a couple of points I will bring in myself, but I'll throw it open to others first, just remind you what it is the paper asks us to do. So it says, having listened to what we have, it says it may be helpful for the partnership to consider whether there are other areas of joint activity that could be explored, whether there would be merit in setting out in greater detail a shared agenda that could contribute to the delivery of the economic strategy, and whether there are any early wins, and it cites there, for example, the Employment Task Force that David mentioned, that could be taken forward in the short term, but clearly that could be any number of things. So that's, I think, the set of exam questions. I'd be interested in colleagues' comments. Paul, you were first off the blocks.
Thank you, Chairman. I'm Paul Bartlett. I'm representing East Kent districts, and I'm also chair of Kent HOSC. This is clearly a vital piece of work. Barely a week goes by, for example, when we're told, or we're not told, that recruitment is a key issue which is holding back delivery of health across the county. And there's an important project which has been started in North Kent, which I wanted to alert you to, which is being managed by Simon Dunn from the Heron Medical Practice in Swale, to create an attraction package. And I think it's very important that we work together on this in order to ensure that we can ensure that the recruitment issue, which it's not just the NHS, GP surgeries, etc., that are facing, it's also other industries, businesses across the county, difficulties in getting bus drivers, for example. Almost every sector is having difficulty getting people into Kent. And there's a range of issues as to what that is. People might not want to move to Kent. There are constraints in the workforce. But here it is. We can help to some extent, but we need to be told what the constraints are. Is it access to education in the right place? Will people come into Kent if they can't get their children into the right schools? Is housing an issue? And then the district authorities come in about their housing provision. Health and well-being, for example, is a very important part. And I think we've also got to sell Kent to people coming into the county. So what I would suggest is this project is in its embryonic phase. I think we should hear how it progresses, let's say in the next 6 months or so, and learn some lessons as to whether this project is successful or not. The metric I recall is they're looking for 13 full-time equivalents to be recruited across the 3 areas, Swale, Thanet and Medway. Might be higher than that. And I think if we can have a report back in due course as to what has caused that to be successful or otherwise, I think it very neatly links into this, the wider economic strategy. Thank you, Chair.
Thank you very much, Paul. Other comments? Sorry. Sorry? Oh, Paul, were you first? Sorry. My apologies. I'm actually having a bit of a problem seeing over the top of this, actually, so I need to pull myself up. So.
I have no problem, Chair.
I think both vice chairs are actually quite strategically placed, and I seem to be absolutely in the wrong position. I will come to Paul first, and then come to you in a second, Sati.
Thanks, Chair. And I suspect Sati and I might want to cross over in terms of some of the things that have just been mentioned by Paul. I think on the broader 3 questions that are at the bottom of the report, I think on behalf of the Integrated Care Board for NHS Kent and Medway, we would support them all. I think they are the right areas. I think there's a particular question that was posed in the report about employment. And I would absolutely accept that offer in terms of joining the task force on behalf of NHS Kent and Medway. I think that Paul's observation, so the work that Dr. Simon Dunn is doing is being done on behalf of Kent and Medway, albeit it's being trialled across that patch in the north. And I would absolutely agree with Paul's observations that all of the evidence about how you can recruit and then retain general practitioners, and it was primarily aimed at GPs, is not just about the practice, but is about the schools and the housing and about the wider roles. It is a conversation that we're already engaged in with the Greater North Kent Partnership. So happy to play that back, and I think we've a date. I'm looking at Alan. We've a date to come back and have a bit of that conversation in later in the year. It may be before the 6 months, but absolutely replicate that. But I think it can act as a learning and it can act as a signpost towards how we can recruit and retain the wider workforce. Thanks, Chair.
Thank you very much. Sati, you're next.
Hi, I'm Sati. I'm the GP partner member. I also am involved with the GP Attract package, but I was going to say...
Sati, apologies. I think it is a little hard to hear. Apologies.
I was just going to say I'm actually involved in the GP Attract package, so I do know quite a lot about it, and we can bring a paper back, definitely. But I was actually going to bring up something around the fuller stocktake report. I don't know if you're all aware of it, around integrating primary care and the population-based care-centred approach to looking after our patients and health and well-being. And I think this fits completely with what we're trying to do across the system. And one of the things I think I've written lots of notes was around how can we work together to actually grow our own. So yes, we've got Kent Medical School. We aren't going to get GPs for the next 8 years if we're realistic about training and everything else. But why are we not having careers fairs together? So very operational, but there are some real simple wins that we can be having or sharing as opposed to trying to recruit as a big piece. And the other issue for me around recruitment it's not just about recruitment. We need to retain. We're training all these people up and they are all leaving Kent and Medway, and there are reasons for it. Additional roles are my personal concern because I'm a primary care network clinical director and we have no estates. So can we start thinking outside the box? The NHS has no money, the NHS has no estates, but actually can we start working with our partners? We are in Medway Council and we're working with our community hubs, but how can we replicate that so that we're making the best use of the resources that we have, because nobody's got any money. So that's it.
Nope, thank you, that's great. Alan, you'd been indicating earlier.
Well, I agree with that, Sati. Nobody's got any money, that's for sure. But it's all relative, isn't it? So I wish Medway Council was as hard up as the NHS, but never mind. We won't go into that. In response to David's question, yeah, of course we'll endorse this and do everything we can to help. As a local authority, of course, we'll do that. My concern is about establishing outcomes and measurable outcomes. And I think if we just refer to the report, the penultimate paragraph in section 1, I'll read the offending piece to you. Over 70 million working days are lost each year to mental ill health alone. In Kent and Medway, this is likely to equate to. So I think if we are seeking to make improvements, we need a bit more precision, and I get the fact that that's the information you've got, David, but if we're dealing with stats that are likely to be X, Y and Z, that's not a good place to start, because if we're to work together towards outcomes, we've got to know what the baseline is to start with, whatever that outcome is. That seems to me quite obvious, because otherwise how can you measure success? And I think the list of things that Paul read out just now, which is under next steps, which is a prognosis. The final one was greater engagement with the Medway Employment Task Force, which is all well and good, but that's a process. That won't actually lead to any tangible outcomes that I can see. It will pave the way for them potentially. So I think this is such a massive problem. It's a bit like how do you eat an elephant, isn't it? Piece at a time. So I think if we are to work towards quick wins, we have to collectively identify what those are, and I don't know what they are myself at the moment. and why would I? We have to identify what those are, establish measurable outcomes, and collectively work towards those piece by piece. So that quick wins really are quick wins, because it's an easy term to use. It's a term I hate, actually, but that's exactly what we should do. We should have a number of outcomes that we want to achieve, and work our way through them on the basis of what's deliverable and what's most important, and how we prioritise what those outcomes might be. So I think what I'm saying is we all accept this is a really important piece of work, but it's also a really difficult piece of work. But working towards some tangible outcomes that we can actually hit some targets, that would be really good and help everyone. The final thing I will say is the table on Introduction to Health and Economy, which looks at female life expectancy at birth. Just as an example, I guess, is it mentions the Medway and the relative district councils, and of course there are lots of variances within those, as we all know. So Medway, for example, because I know Medway well, has some of the richest wards in the country and some of the poorest. And I guess quite a lot of the other council areas are the same. So it's trying to work out what will make the most impact most quickly. So that's a pretty good question to answer. Thanks.
Thank you, Alan. I've got Valerie, then Shane, then Angela, in that order.
Thank you. In many respects, my observations are similar to those of Councillor Jarrett. But first, I'd like to say that I thought this was a really great piece of work. It was wonderful to see Kent and Medway delivering an economic strategy together, and that is without doubt having something that crosses the piste of the ICB, so to speak, a real benefit to us. I also thought that the 5 themes are right, because what the strategy is doing is not only investing in people, but also proposing how we might invest in place. And it's the two things together which will help deliver that inclusive economic development and sustainable outcomes. I can also see how, when we get this right, it will help us in terms of health and social care, because in theory at least, we should be able to deliver workforce development to help recruit and attract and retain new people. But where I do struggle a little bit is, well, yes, I can measure and see positive outcomes and benefits. Say, for example, we could tally, literally, couldn't we, the number of, say, new GPs that we had managed to recruit, in part on the back of this economic development strategy. It's much more difficult to track and literally record the outcomes in terms of the public health benefit. And I was reminded a little bit when I was reading this of that sort of old Oxfam adage that, you know, if you give a man a fish, you feed him for a day, you teach the man to fish, and you feed him for life. And there were lots of studies done in the Isle of Dogs where at the outset of this, you know, establishment of the enterprise zone, it was literally in the most disadvantaged borough in terms of inequalities, poverty, and so on, in Poplar. And although the programme was absolutely phenomenal in terms of economic development and just straight business success, if you like, when after about 20 years they then reviewed again the data for the local population, it had barely moved in some wards in Poplar. And the reason for that was that people had literally become upwardly mobile and moved out. And because Tower Hamlets is one of those boroughs that was literally set up to welcome those in need, and therefore many more came, actually the data didn't change. So it's not just about the data, but it is about capturing, if you like, the patient end and how we do measure, quantify, and understand the positive health benefits that would come from economic development and can prove them in straight public health terms. Thank you very much for a great strategy anyway.
Thank you, Valerie. I think it's a very valid point. I always remember, I think at various times seeing evidence where you regenerate a place, whether you always regenerate the people in quite the same way is one of the great challenges. Shane, I think you're next, then it'll be Angela, then Sedi.
Thank you very much, Chair. A couple of observations, if I may. First, I welcome some of the language in this. It is a nice welcome departure, how this is more about delivery relying on all of us working together as partnership rather than being a more top-down approach, be it from government or from any other particular level. I think that's to be welcomed. I'm going to jump on something Alan said about quick wins. I'd rather get it right rather than win quickly. And I think that's going to be important. If we can get quick wins out of it, that'd be great. But I'd rather get it right rather than rush to get something done and then half-bake the idea in. You asked for some feedback as to what's missing. I would argue of the objectives for consideration, something about it being a bit tailored and holistic. We have a very large county. We have a very large, diverse area that, and you know, it says this strategy must align with framing Kent's future. That's great, but there are other already local economic development strategies in place of all our district and boroughs and other voluntary groups. This got to align to first. If you align it to framing Kent's future and don't align it to the rest of them, then it's going to fail at the first hurdle without that particular engagement. So it's got to link to those strategies. It's got to link to the priorities set down by government for the ICPs, rather than just aligning to that one. And that is where its success will be. The key concern I have is around governance for this. Kent and Medway Economic Partnership has some statutory basis via the LEPs. The greatest respect to Roger and to Alan, Kent and Medway leaders doesn't exist statutorily. It can't take any decisions. So it can't be owned by them at all. It is, for all intents and purposes, according to terms of reference, a very useful strategic talking shop, and it's important we collaborate and work together, but they can't own anything. And so therefore, while KMEP may be an important body in terms of powers, Kent Leaders has none. So we can't bypass the governance, accountability and scrutiny, and that's going to be key to its success. I wondered how long, David, it would take someone to mention KPIs and dashboards and scorecards. Thank you for giving me the hook for my hobby horse about the obsession with them. If there is no qualitative data, there is going to be no point. Who's going to be served by whole teams doing dashboards and scorecards? What, here? Frankly, it's not about serving here. It's not about serving the dashboards and scorecards. It's about out there. And frankly, that's the outcomes I want to see: increased public health. I don't want to see a scorecard here that doesn't actually lead to tangible benefits out there. It's not about serving in here. It's definitely got to be serving out there. So I would argue, if your three objectives, if you could add maybe tailored and holistic to that, because it's got to be. That's the only way it's going to work, to make sure it meets our VCE colleagues, our local districts of ours, and the Kent wider strategic partnership. Because otherwise, if it's going to be too disjointed, you cannot have a one-fits-all approach, because it's not going to work, given the diverse and fantastic nature of the county we have. We've got to celebrate that diversity. Bringing it all together in one may end up breaking before it even starts. Thank you, Chair.
Thank you, Shane. Before I move on, I'm actually going to abuse my position as chair slightly, because just to put in a contribution to this, which is not so much my own, but a few points that John Goulston raised, which he asked me to pass on as part of this. So I do think he raises some very interesting points, which is looking at, and it comes back to this point I mentioned earlier on about the role of NHS and indeed other related institutions as anchor institutions, and the role that they therefore play economically and how that can contribute to this. So there were three examples he picked out. One was around workforce, clearly a major opportunity to recruit local people in the health and care workforce at all levels. Broadening the use of apprenticeship schemes across health and care providers is an obvious opportunity. Talks about what is done at Kent Community Health, and many other models also within Kent and Medway could also be built on. So I think that fits, and it fits with what was being mentioned earlier on. And perhaps also that point about the relationship, given indeed that the Employment Task Force certainly has apprenticeships also within its viewpoint. But I think the importance of that as an area in which health and care institutions can play an important economic role, I think is well worth picking up. He secondly mentions the East Kent Hospitals business case, successful progression of that to provide fit-for-purpose hospitals in East Kent, big opportunities in terms both of construction and delivery of the scheme, but also, going back to a point that was mentioned earlier on, the boost to recruitment and retention that would follow from that. And finally, suppliers, NHS providers in Kent and Medway individually have procurement policies to encourage the use of local suppliers. Could this be standardised to best practice? Focus on social value and sustainability in tendering and contract management. And there is models of that within the NHS. And indeed, of course, that approach is a big focus for certainly for Kent County Council in our approach to commissioning, and I'm sure for other authorities too. So whether there is something that can be developed jointly on that becomes also an important part of the relationship that those major institutions have to local businesses, local VCSE organisations, etc. So I think there are 3 points of considerable validity there in what John has raised. So I just thought I'd pass those on as part of the debate and then move on to Angela. You were next.
Better? Good. Angela Harrison, Swellborough Council. David, you triggered something when you talked about planning and healthy communities, and what you triggered was 106 agreements. I haven't sat on the planning committee apart from the odd sub for three years or so, but I did have a number of colleagues on the planning committee come to me and say, why isn't the NHS asking for more money earlier? I did some digging with the officers, and it turned out that Medway Council have already got agreed the threshold at, I'm making this up because it's gone, but 20 houses, you get an NHS contribution, or 10, whereas Swell was higher. And I said, this is wrong. There should be the same threshold right across Kent. If you build one new house as a developer, you are costing the NHS money. So, you know, I know we are where we are, but moving forward, can we look at the threshold for 106s? So instead of you build 20 houses or more, then we want a contribution for the NHS, make it 10 or make it 5. And planning committees will implement it. As I say, there is an impact on your budgets whether one new house is built or 30 or 40 or 100. So really, I think that's something that you should look at, because what we get told by our officers is, well, you know, that's what the NHS wants. Well, okay, we are in a new ball game. We're working together, and I'm saying to you, tell us you want more money at a lower threshold. And the other thing, of course, is the 106 monies. I think a number of colleagues on planning think that you need to be more imaginative with the way what you ask for what, because we're told, oh no, it's only for capital. Well, actually, you can use capital monies for revenue projects. It is not, you know, it is not outside of the box too much. But also, what the NHS describes as capital, we as a local authority would consider revenue. So, well, it's only £17,000, there's not much we can do with it. Well, so you're going to give the money back to a developer then? You know, I'm not going to say, oh, my dead body, because I'm not the one to grab the money, but you need to be more imaginative to get the money out, because, you know, yeah, we're all skint, but there is money there. And, you know, our NHS colleagues have only got to ask, and we'll be putting it on there on the no, we want that. No, we want that. Well, no, sorry, go away and tell us, come back when you can tell us you can afford it. So there are opportunities, I think, if we work together. Thanks, Rog.
Thank you. I think one area where that perhaps helps is if we're looking at the growth and infrastructure framework, or do we still call it that, don't we? Do we, Stephanie?
Infrastructure mapping platform.
Infrastructure mapping platform, there you go. I'm showing my age. That very much incorporates a full range of the implications of growth on infrastructure, and that's not just typical local authority infrastructure, important though that is, as I would of course say, but it certainly very much incorporates health, as well as indeed the wider questions of areas such as utilities as well. So I think that's probably a channel through which to work on that. Sedi, can I come to you, and then I'll endeavour to sum up, because I'm conscious of time.
Yeah, thank you very much, Chair. Sedi Frederick, Chair of Kent and Medway ICB, and I'm conscious of time, so I'm not going to repeat the comments that have been made, but just a couple, if I may, just broad overarching comments. One is about tone in terms of the strategy. It doesn't give me a sense of confidence. This is not wordsmithing, but when I see words like potential and things like that. So on page 3 of the covering report, potential areas for cooperation include. My expectation is that by now we would have thought through where these areas of cooperation are needed to be, and we would give ourselves, or give a sense of much more assertiveness in terms of confidence to the reader, but also to those who will be following on to undertake the detailed area of work needed to support this and deliver this. I'm also very conscious that if this is a strategy to 2030, there are now children entering secondary school who will be in the workplace by that time. So I'd like to see a much clearer relationship with education, for example. I'd like to see a much stronger push towards affordable housing. It makes passing reference in the document, but I'd like to see a much stronger emphasis. And it may well be that for purposes of brevity, you don't want to overload us with page after page after page. Transport, for example. So all of these enablers, I'd like to see writ large in terms of we understand that to deliver this, we will need to engage with other parts of the Kent and Medway ecosystem. So that's just, if I may, just in terms of a general observation. And can I use this item, and it may well be that this is a discussion I've missed somewhere along the way, but given how important the notion of place is in all of our thinking, can I invite us to perhaps take some time to reflect on what we mean by place? Do we have a common understanding of place? It's a word that's thrown around left and right, but I'm not sure whether we have one version of the truth in terms of what place. Is it a geographical place? Is it a political place? Even within place, there are communities that would not consider themselves to be part of a place. So can I use this as an opportunity, through you, Chair, just to invite us to reconsider, or not reconsider, but at least bring that back for consideration, this notion of place, because it frames much of our conversation to thinking going forward. Thank you.
Thank you, Sedi. Thank you to everyone. I think we'll need to draw this one towards a conclusion. But I think the question that we need, to go back to what it was that we were seeking to achieve here, areas of joint activity that could be explored, merit in setting out in greater detail a shared agenda that could contribute to the delivery of the economic strategy. And then we've spoken quite a lot about early wins or quick wins or whatever. I think the question that we do need to nail down at this point is the relationship between this document and its ambitions, the ultimate development of our integrated care strategy, and how particularly the role of health and care institutions bring those two together. So I think perhaps a question would be, and maybe we pick this up, I would suggest that we ask for this to be taken up outside the meeting, but my steer on it would be that as we are developing, and we'll be discussing this a little bit further later on, the integrated care strategy, then how much of a role within the integrated care strategy does some of the kind of things that, Paul, you were talking about, or the things I cited from John Goulston and indeed were mentioned by others, play within that strategy? I don't mean very specific objectives, but I do mean a direction, because I think what I would like to envisage is that that there was a very clear and seamless link between this economic development strategy and the integrated care strategy, and that we make clear in that some of the ways in which that can be delivered. And I think there are a number of points, both in terms of what the paper lists and indeed the points that others have made in the conversation, which I would suggest be a good way to try and bring those together. Does that seem like a sensible agenda? So can I suggest then that if David and Stephanie on the one side and the team bringing forward or carrying forward the work on the integrated care strategy on the other, work on that, that gives us that shared agenda, and then we can actually, I think, from this, and whether, I gave some quite concrete examples, well, I didn't, I was giving it on behalf of John Goulston, but it's that sort of level, I think, where ultimately we can, without saying it's necessarily those specifically, but those things that contribute to both strengthening ultimately what we get out of the economic development strategy and giving some real content to the integrated care strategy as well. Is everyone content with that as a way forward? Yep. Great. Thank you all very much. And David and Stephanie, thank you. Right. Chairmanship has fallen down on the job as usual because we're now a few minutes behind schedule. So if you bear with me, we will move on now to the development of the integrated care strategy. And we've got another half hour on this before we have our break. So I believe on that it's James and Anjan to lead off on that.
Thank you, Chair. I'll start off. I'm just wondering, Chair, with your permission, if we could bring Vincent to the table. Vincent,
yes, please do. Vincent, welcome.
So I'll start. Vincent, do you want to introduce yourself?
Thank you. I'm Vincent Badou. I'm the incoming Chief Strategy Officer for the ICB.
So we'll do a triple act. I'll start and then James and Vincent can fill in some of the gaps. We have a really good story to tell, really, in terms of how closely we're working. The strategy, I'd like to assure colleagues here, is progressing at pace. As we all know, but I do want to say this is an unprecedented opportunity to coordinate and focus the system on this really wicked issue of health inequalities and prevention and the wider determinants of health, among other things. The basis for that part is the Robert Wood Johnson model. So that's that 40, 30, 20, 10. So 40% is wider determinants, 30% is behaviors, 20% is around healthcare, and 10% is around built environment. So all those factors contribute to well-being and health. So that's the model that we're going with. Vincent's the SRO for the development of the integrated care strategy, and we've developed a project team in which we're working at different levels. So we've got a steering group, a planning group, and various working groups which have been established. Very recently, in fact, last week, we shared the JSNA report, the annual summary, with the Kent Health and Wellbeing Board. So if this board is happy for us to share it here, we're happy to do so. It's a really good summary of Kent's position, and I know that Medway is doing the same in Medway too, and they would be able to share that as well. The way we're developing the work is to achieve a common set of priorities. So try to work out vision, which actually already exists. In a way, the ICS vision encapsulates what the vision ought to be, but that's what we're working with. a mission and a set of common priorities, which effectively becomes the plan on a page. We're structuring the one of the chapters at least to do with tackling health inequalities and prevention on the basis of people, place, policies, and practice. We're also working quite closely on engagement. So when we were developing the Kent Public Health Strategy before, we were planning, which is captured in point 2.4, an approach towards communication and engagement. However, what we're doing now is to work really closely with Integrated Care Board comms and looking at how we can work together and phase it in a suitable way. In fact, tomorrow there's going to be a multi-partner brainstorm session with the principle of do it once approach. Now, what we're broadly doing in engagement is in 2 steps. There's a lot of engagement which has already taken place over the last 2 years. We've got multiple feedback about, in a way, consultation exhaustion. So asking the same thing over and over again, getting the same frustrated replies and nothing really moving on that. So what we're going to do instead is consider all the recent engagement work, and that's what this brainstorm is about, and draw together what we can from that, include work recently done, for example, by Kent and Medway Listens. We did a lot of work recently in the pandemic on vaccine confidence building and other bits of consultation. So the idea is to draw that together, collate it, and identify what further information we need, and then basing the next steps on that. So make a plan to address that. I'm personally very still keen to maintain a kind of a 3-prong approach, particularly with the the community conversations piece, where we get our system leaders to engage with groups of people and listen directly and feedback and really remove all those barriers and have that listening exercise. But that's probably going to be more in the future, in the next year, because the top priority right now is to deliver the December deadline for this. I said about the plan on a page, vision, mission, all of that. Along with it will be 12 chapters. So what we're aiming for is roughly a 50-page report. Each of the 12 chapters, which is there in section 2.8, having about 2 pages. So it's really top line at this stage, because it's about really setting down the stakes on what we plan to do. The detail will follow post-December. So I'm not going to go through each and every one of these 12. They're all there, but there are a lot of them where public health colleagues in my team, in James's team, are working directly with the ICS, especially around disparities in health and social care, population health and prevention, health protection, this life course one, from babies till healthy aging, research and innovation, data and information sharing. So those are the areas where there's, in any case, natural collaboration, and we're working on that. Do you have a question?
Really sorry, but on that particular point, we're all here struggling to, you're referring to things that don't seem to be in the papers. And so these 12 points, when you even mention 2.8, the paper we've got goes to 2.7, so we're struggling to, we're looking drastically through our papers, but we don't seem to have what you're referring to.
Sorry, I got a different version of this. Very many apologies for that. But the content is more or less that. Sorry for that. I've got a different version out here. Now I'll end. I have come to the end of my piece by saying that we're hiring a consulting company to produce a strategy based on what comes out from these chapters. And later on, in late October, there's a system-wide event which SEDI is inviting people to, which will really be an important point to bring together engagement around the draft strategy. So I'll end there. James, do you want to say anything? And Vincent?
Thanks, Chair. I'll pick up at that point. I think the next meeting in October will have more granularity in relation to progress, and I think that's probably why Unjin's just given a little bit more detail to members now, but we will be topping and tailing that. I just wanted to actually pick up a couple of points really in terms of the discussion that we've already had. One of the points that was made earlier was around quick wins. I think the benefits of working collaboratively, and I think we've already heard one item in terms of housing is that there are things currently that will make a significant impact on our population and our outcomes. And what we need to do is to get around those things to make sure that we're all clear about what it is that we can do to maximise the benefits of working together. I think that's probably where I'd be going in relation to how we can look at those types of quick wins. Just by way of proxy, if we look to the debate that we've just had in relation to the economic strategy, the additional paper that's in the appendices, and hopefully that is there, and it looks at some of the examples of the work that we're doing to contribute, it does set out the reasons why. It talks about community safety. We know that unfortunately some of the families that are more likely to have poor health outcomes are families that are involved in the criminal justice system. So working collaboratively around some of those strategies, bringing those things together, means that we'll deliver better health outcomes. Quite clearly in there it talks about the economic strategy and things like that. We're aware of those. But one of the other things that I wanted to think about was the skills agenda. We've talked, and I think Sedi referenced it, again, around that link with education. We know that from education comes health. So people who have got higher levels of education, you know, if you've got a first degree, master's degree, PhD, ETL, you're more likely to have better health in general terms than people who haven't. So there's a very clear link to get the broader determinants of health embedded within the way in which we do things around here and join up our bits of our system. I think one of the other points that I personally just want to touch on is the granularity. We talked last time about the data, and this links back to understanding place. We're really clear now about having the ability to mix and match the information that we've got and not just look at data, but turn that into intelligence, because it's a so what question. So we might know about this, and I'm sure, Shane, in our last meeting, this was one of the points that you raised. We've got lots of data, but actually, what are we doing with it? And that's really mission critical to how we want to work, and I'll go for that. I think we've all heard, perhaps today, around the impact of interest rate rises. Now, potentially, proportionally across our population, depending on where people are sat, we know that there will be significant chunks of our communities who will be, you know, quite severely impacted by some of the fiscal issues that are happening at this moment in time. So alongside this, we know we're doing another piece of work, which clearly will come to the next meeting, around the impact of cost of living, but all of that means data and information needs to be turned into intelligence. Unjan's already mentioned the work that we're doing collaboratively across the scene. It isn't, again, just health data sets or public health data sets. We're looking at that broader spectrum of information that's out there that will enable us to make the appropriate decisions to support our communities. Unjan's touched really on the broader outline and give you an overview. In our next meeting, we will get into quite a lot of the detail, because we'll have quite a strong draft and hopefully be in a position to share some of that with colleagues. Vincent, I don't know if there's anything else that you wanted to add to some of the work that we're doing.
Thanks, James and John. As you've already set out, I think we're recognising this is quite a rapid piece of work that we're trying to take forward. So the national guidance and timetable requires us to develop the integrated care strategy first iteration by December of 2022. And as James and Antoine have set out, that will be a high-level strategy initially that will set out our ambition, but also our priorities. And then we'll need to iterate that work during the period January to March 2023, so that we can ensure that those priorities are translated really clearly into an implementation plan and a forward plan to take us forward as an integrated care system, both through the next fiscal year, but also beyond that. So from the point of view of health services, I think it's really important that we acknowledge that in addition to having the integrated care strategy, we are expecting a refresh to the long-term plan priorities as well. And we'll need to ensure that actually our work in the integrated strategy in terms of our commitments also look at how we will implement those over a longer period, which could be up to 5 years. And therefore, what we will be doing through the NHS is to ensure that our forward plan really is looking at how we implement the integrated care strategy, both at a system level, but also through our places and our neighbourhoods. And I think that's really important in terms of being able to demonstrate that there really are measurable improvements and improvements to the outcomes, both health and care outcomes, for our populations across the county. So again, as James and Andron have said, I'm coming into role as taking over as the Senior Responsible Officer. What we will be doing is ensuring that the Integrated Care Partnership Board, which is the lead board for this area, is well cited on a regular basis on the progress we're making, but also how we are engaging with our stakeholders across the system to really look at how together we can drive forward the implementation of our priorities, but also look at the work that's already going on at a local and place-based level, and how that informs the opportunities really to shift some of our resources in particular, but also to engage with a wider group of stakeholders. And here I'm really talking about partners across the voluntary and third sector who are key to helping us deliver on the ambitions of our integrated care system. So again, what we really are wanting to focus on is not just the role that larger statutory organisations play, but also the wider role that local communities and those third sector organisations play in working alongside us in helping us deliver this at a more granular level. So again, just to give you that assurance, and I'm happy to build on that in future reports when we come back to the board.
Thank you very much, all. Any comments or questions? David.
Right, we're connected. Thank you. An extremely good report outlining a whole load of opportunities that are already in place across both Kent and Medway for the benefit of the communities. But I'm just reading through the report once again. I've been reflecting on the years that I've been involved as a councillor within Medway, only to find that time and time again the same issues are being brought up and raised as an area of concern that needs to be addressing. One, of course, is in fact domestic violence, and certainly in all the time that I've been a councillor, and I would say many years before that as a serving magistrate here in Medway, domestic violence was certainly an area of great concern. And certainly as a magistrate, when I was active, it was certainly good to see that responsibility for pursuing domestic violence cases was in fact taken away from the alleged victim, to the point that out of the hands of the alleged victim, the police and the Crown prosecution could in fact move forward and deal with issues. And I'm just raising this as a point because domestic violence is mentioned in at least 3 of the headings that we see in the report today. The other area I'd just like to point out is the Medway Go. And it points out on page 4 of or page 43 of the overall report, the fact that Medway received £1.1 million in government funding to offer activities and lunches to children eligible for benefits related free school meals and the like. This really for Medway has been quite a success story, in as much as that we were able to help families that were in need by providing activities for those children, for those families, and at the same time, because they were in our direct care, we were able to make sure that those young people received free school meal type refreshments. So we were looking after them. But unfortunately, in some areas of Medway, the community got this totally mixed up with another scheme, and that is that if families required additional financial support, then they could in fact apply for a grant that would cover free school meal equivalents during the school holiday. This led to a little bit of confusion within Medway, and it took 3 radio interviews and a television interview before finally the message got across that there were 2 separate schemes. One is about children and families that could apply for grants to cover meals. The other one was about providing activities and supporting families that really needed it. Now, I'm just picking these 2 examples out because there are many more examples here of very good practice. And I think each and every one of us sat round the table together with our local authority or our district council. There is so much to learn and so much that we can offer within our own communities. And I really would like to see that capitalised on to make sure that we learn from what is in here, we share that information, and Kent and Medway will benefit, and certainly our communities will as well. So my message is certainly a good idea. Let's work together. Let's share what we've done, pick out the good bits, pick out the bits that possibly where we've had issues, and collectively correct those issues so we don't fall over on the next round. Thank you.
Thank you. I think that's an important point, which I will come back to when I try to sum up. Claire, you're next, then Sedi.
Hi, I'm Claire Cardy. I'm one of 2 new VCSE representatives on this committee. I just wanted to reinforce the point that Vincent made about the contribution of the VCSE sector, obviously. And I noticed in the appendix many of the examples of what's called health-related services, things like domestic abuse, things like social injustice, food poverty, all of those services, many of them are provided by charities and voluntary sector organisations. So I just wanted to make that point. And obviously we know that every organisation is suffering with lack of money at the moment, but particularly the VCSE sector is particularly struggling at the moment. And I know that many charities and organisations are seriously considering how they can continue providing services. So I think we need to bear that in mind. If many of those organisations and services don't continue, the impact that's going to have on the wider health and well-being of Kent and Medway.
Thank you very much, Claire, and welcome. I'll come next to Sedi and then to Anne.
Claire, I wasn't aware that you could read my notes from over there, but thank you very much indeed. Really welcome this. I really think we're onto something now. I'm really, really pleased. So thank you very much for all the hard work that the teams have been doing to get us this far. I make no apologies for sounding like a broken record on this point again, but I'd ask us to ensure that even between now and the December deadline, we make every effort to consult, even with this headline level report, with more work to do. I think with technology, we can organise 2, 3 quick events where we can actually get an endorsement, even at this early stage, from stakeholders, from partners, to work together to take it forward. And that will give us confidence when we submit our initial document at the end of December. And I guess I'm not sure if this is a question I should have asked Paul outside of the meeting, so he may well wrap me on the knuckles as we leave. But the thing that worries me slightly is about the fact that how we link this with the ICB's planning cycle. And because I'm conscious that already thoughts have been given to next year and so on and so forth, in terms of influencing the ICB's thinking, planning, financial strategy, can we get any sense at this stage, maybe too early, Paul, of how this will influence our thinking, given everything else that's going on at this point in time? And you can tell me off later, but that's okay.
Shall I come back on that, Chair? Apologies.
Please do.
I know that Anne's going to come back, but we'll have a private conversation between the 2 of us. The short answer is it must and it will. What is recognised, and I absolutely echo your comments, Chair, which is that the 2 Directors of Public Health and Vincent have worked really hard to get it to this place. And what I absolutely recognise, and I think Vincent mentioned it, is that this will be this, what comes to here in December will not be it will be a step towards it. So what we are doing is we'll take that emergent work, share it into our ICB planning cycle, iterate it and keep on iterating it out. So the two will work hand in glove.
Thank you. Funny enough, I was going to raise a similar point, and clearly it applies across a whole number of organisations and for planning and indeed budgetary cycles as well. I suspect, to be honest, there's going to be a much more, well, I hope there will be a much more dramatic impact on, or significant impact on budgetary decision making for 24-25, which realistically, but we do need to get it into all elements of the cycle as early as we can, I think. So thank you for that. Anne.
Thank you, Chair. Good afternoon. My name's Anne Taylor, and I'm the Chair of the Kent Integrated Care Alliance. So we're a representative body of around 450 independent private social care providers and health. I was just looking at priority 4, which is to work with our partners to build and grow our social care sector. And I just wanted to pick up as kind of like just thought-provoking or just to think about it. I think James said about interest rises, the retention of social care workers is going to decrease because obviously it's those frontline workers that are going to be affected by higher mortgage rates. They can get better paid jobs outside of the social care sector. And as providers of social care, we are expecting a harder winter this year than we've ever had. But actually, retention of our staff isn't great and will get worse. The other thing that I just wanted you to consider is that actually a number of providers are considering now the government drive for recruiting overseas workforce, and that will bring a number of people into our county with different cultures, with the needs for housing and other kind of economic support that isn't there at the moment. So, you know, there are a number of people coming into the country under their sponsorship schemes, but actually housing these people in appropriate housing for them to support our elderly and most vulnerable in our communities absolutely got to be considered. Thank you, Chair.
Thank you, Anne. I thought I was already worried about the various pressures on housing, indeed some of the conversations we're having, given the whole range of particularly national schemes which are adding to this. Well, you've just reminded me of another one, Anne, so thank you. Very important point. Right, is there anyone else on this? If not, and then we are actually only 5 minutes behind time on that point, seek to draw this towards a conclusion. Just a couple of points. I think as was mentioned earlier on, I was checking my diary, so we have our next meeting on the 19th of October will be the occasion when I think we see something that is, you know, getting us towards a material step towards that December deadline. And then, but it's not too late because most importantly, 9 days after that, and yes, Sedi, it is marked out perfectly in my diary, the famous symposium is due to take place, bringing together leaders across the system to seek to really, really brainstorm on what it is we want and what we want to get out of this. So I think those are going to be two very important dates. And I think the other point I would mention, it picks up on the point the number of colleagues made, is right towards the end, I think it's 2.7, given the importance of partners tackling the wider determinants of health in order to best tackle local health needs, a menu of potential interventions that each partner might take will need to be developed. And I think that also ties into the point about what works and learning from experience. So, because I think we have, all of us over the years, had many, many occasions when, broadly speaking, yes, we know what the big issues are, certainly what the needs are, but tying it to something that actually is an intervention that one partner or a group of partners will be able to deliver, and that we have confidence is a good use of the scarce, very scarce now, available resources, I think is really, really important. So that's again going to be part of how we develop all this. But Can I say thank you again, as others have said, to the fact that we're clearly making progress on this. It is essential. We know that we've got the usual joys of a national deadline for December, but that is only one staging post in the process. But equally important, we make real progress on that so it can tie into all the planning and budgeting activities as soon as it possibly can. So it's kind of iterative, but I think we'll take some important steps of that at the next meeting. Good. I think we're just asked to note the plans and progress around developing better understanding of system priorities owned by partners and driven by local needs. So I think noted. Yep. Good. Thank you. Can we give ourselves probably 6 or 7 minutes to get a cup of tea or whatever, and then we will reconvene for the rest of our meeting. Thank you. Whoops. Right. Okay, sorry. Moving swiftly on from the interesting conversation which is going on here. Right, welcome everybody back for our remaining items. And so the first one, which I'll come to Mike for, has the quite long title, which clarifying the relationship between the Integrated Care Partnership Joint Committee and the Integrated Care Board Inequalities Prevention and Population Health Committee. Mike, over to you.
Thank you, Chair. For those of you that don't know me, I'm Mike Gilbert. I'm the Executive Director for Corporate Governance for NHS Kent and Medway, and also responsible for governance across the wider system, including the ICP. Hopefully, Chair, this is a fairly straightforward item, and I'll take it as read. It's really a governance clarification issue in terms of, in the first couple of meetings, there were conversations or comments made in terms of just not understanding the relationship between this group, so the Joint Committee, the Integrated Care Partnership Joint Committee, and the ICB Inequalities Prevention and Population Health Committee, which is a subgroup of this committee as well. So this paper just hopefully clarifies the role and relationship between those two groups in terms of going forward. I'll take the paper as read. I don't think I need to go into in detail because it's a very, very short paper, and just happy to answer any questions, Chair.
Mike, thank you very much for that. Does anyone have any questions on this? So it may have a longer title than a debate. Right. Okay, but it does, as you say, I think it sets the issue out clearly. It answers the question. I think we're all content with that. So, Mike, thank you very much indeed. Right, we move on now to the forward planner, and I don't know if there is any. I mean, we mentioned earlier on, I think, that we've got certainly for our next meeting. We have, I think, from memory, a couple of key elements, which includes the major amount of development really on the ICS. I believe we're also due to, I'm just trying to make sense of this and understand it fully, that we are looking also to the cost of living issue as well, is due to be coming to our next meeting, is it not? I don't know if there's anything else that we need to add on this or any other comments. Shane.
Thank you, Chair. Just briefly, I believe at the last meeting there was a paper that was sent back for further consideration in regards to a particular committee. It's not the committee we've mentioned here. There was there's the social committee, effectively, of the ICP and its membership and how it's comprised and that lot. I thought it would be here and this, except someone was in the way. But would that not? I can't see it anywhere on the forward plan. Is it something to maybe just pick up outside this meeting as a conversation, either for the October one or the one after that?
Mike.
So whilst this isn't specifically my action here, I do know. So I think what you referring to, Shane, is we were also looking at proposing a second subgroup to this, which looks at the wider determinants of health, social and economic well-being. And I think the group wanted more clarification. So what we can do outside of this, and I think it plays into the strategy anyway, is come back to the next meeting. I'm doing this on behalf of others, so I'll need to just double check with them. But I think that we can come back in terms of where we are with that conversation and whether it is a separate subgroup or whether it can be taken forward via something that's already existing in place.
Thank you. Yeah, I think we had quite an extensive debate on it last time, but I think it probably bears quite a lot of work and thinking outside the main meeting, and we bring it back at the appropriate time and discuss it then, I think, if that's where we go. Good. Are there any other comments or queries on the forward planner? No? If not, then thank you. And I think we then move on to any other business. And I know we do have one item, which, James, I think you're bringing forward.
Thank you, Chair, members. We've had quite a discussion today about looking at outcomes and how we'll be able to understand whether we've done what it is that we've said we were going to do. So we've been given the opportunity as one of only 3 integrated care systems across the country. The Department of Health and Social Care want to look at Kent and Medway, understand how we are doing our work in relation to delivering against the ICS's remit to tackle health inequalities. There's a project, this is being led by the University of Manchester, and it's their, I'll get the wording right, Health Organisations Policy and Economics Research Group. But they've been tasked by the Department of Health and Social Care to do that work with us. What that will entail is from this month, September, we've still got a few days left, through to next year, so that's going to be around about December 23. Some key members from this particular committee, from our committee here and also from the ICS broader, will be interviewed by these researchers, and it'll be about an hour worth of our time. And what they'll be doing with that information is using these findings to inform policy and changes. So we will get some insight as to how well we are doing at achieving our ambitions, but actually what we do here will be help to shape and inform national policy around ICSs and how they work to tackle inequalities.
Thank you. Yeah, I think it's rather exciting, actually, that we have that. And as you say, it cuts both ways, so we can hopefully have an influence nationally, but actually rather good to have somebody else marking bits of our work as well at the same time, and doing so almost in real time. So good. Right, thank you for that, James. Is there any other business? If not, then 15 minutes ahead of schedule, I believe we can close the meeting. Thank you all very much.